Most people think of sleep as the safest part of their day. The body is still. The heart is resting. Nothing demanding is happening. That belief is one of the most consequential misconceptions in cardiovascular medicine. Sleep is not cardiovascular neutrality. It is cardiovascular complexity, a series of physiological transitions, hormonal fluctuations, autonomic shifts, and respiratory changes that place very specific demands on the heart and vascular system. And for adults over 50, whose cardiovascular reserve is reduced and whose sleep architecture is already changing in ways that compound these demands, the hours between 10 p.m. and 6 a.m. represent a period of genuine and measurable cardiovascular danger. The autonomic nervous system undergoes dramatic transitions during sleep, shifting between sympathetic and parasympathetic dominance as the body cycles through light sleep, deep slow-wave sleep, and REM sleep. Each of these transitions produces changes in heart rate, blood pressure, and vascular tone. In a healthy, well-regulated cardiovascular system, these transitions are accommodated smoothly. In an aging cardiovascular system, particularly one that is simultaneously dealing with unaddressed sleep-disordered breathing, dehydration, medication gaps, or temperature stress, these transitions become the moments at which the system's vulnerability is most exposed. The National Heart, Lung, and Blood Institute identifies sleep as a critical period for cardiovascular regulation, noting that both the quality and the physiological environment of sleep are directly relevant to daytime cardiovascular health and to the risk of nocturnal cardiac events. Research published in the Journal of the American College of Cardiology has established that the autonomic nervous system changes of sleep, particularly the sympathetic surges associated with REM sleep and with sleep-disordered breathing, are directly implicated in the nocturnal clustering of arrhythmic events, myocardial ischemia, and sudden cardiac death that make the sleeping hours disproportionately dangerous for adults with underlying cardiovascular disease. Today, we are going to walk through 5 specific nighttime habits that directly compromise the cardiovascular safety of sleep through the lens of sleep medicine and cardiac physiology simultaneously. And then we are going to build the complete heart-safe nighttime routine that protects your cardiovascular system through every hour of the night. Habit number 3 is the one I want you to think about most carefully because it involves the single most common unaddressed cardiovascular risk factor in the sleeping population, and its effects on the autonomic nervous system during sleep are unlike anything else on today's list. And habit number 5 involves a bedroom variable so routinely ignored that most people have never been asked about it by any clinician they have seen. Before we begin, leave your age in the comments. And tell me, how would you describe your sleep? Do you feel genuinely restored in the morning? Do you wake during the night? Do you snore? Those 3 questions together tell me more about nocturnal cardiovascular risk than most standard clinical assessments capture. Be honest, this community is here to support each other. Number 1, eating late and heavy. From a sleep medicine perspective, the cardiovascular consequences of late heavy eating are most directly mediated through their effect on sleep architecture, the specific structure and sequence of sleep stages that the body must progress through for cardiovascular recovery to occur. Digestion requires sustained autonomic activity, specifically parasympathetic activation of the gastrointestinal system. But this parasympathetic digestive activity conflicts with the autonomic transitions required for healthy sleep stage progression. The body cannot simultaneously optimize digestive processing and progress smoothly through the deeper stages of slow-wave sleep, and when these demands compete, sleep architecture is the one that loses. Adults who sleep within 2 hours of a heavy meal consistently show reduced slow-wave sleep, the deepest, most restorative stage, during which growth hormone is released, blood pressure reaches its protective nadir and cardiac tissue repair occurs. Increased sleep fragmentation, more frequent partial arousals that sustain sympathetic tone through the night and prevent the full parasympathetic dominance of deep sleep from establishing. Elevated nocturnal heart rate, as the cardiovascular system continues to support digestive blood flow redistribution into the sleep period. And from a specifically cardiovascular perspective, the disruption of nocturnal blood pressure dipping that these sleep architecture changes produce. The dipping pattern, in which blood pressure falls 10 to 20% during sleep compared to daytime levels, is one of the most powerful cardiovascular protective mechanisms available to the sleeping body. It reduces the mechanical load on arteries, reduces myocardial oxygen demand, and allows the endothelium to repair the oxidative damage of daytime blood pressure exposure. Late heavy meals disrupt this dipping through the sustained sympathetic and metabolic activation of digestion. And adults who are non-dippers carry a cardiovascular risk profile that is measurably and significantly higher than dippers of equivalent daytime blood pressure. A study in the International Journal of Cardiology found that late meal timing was independently associated with the non-dipper blood pressure phenotype after adjustment for BMI, hypertension status, and caloric intake, confirming that it is the timing, not just the content, of the evening meal that determines its cardiovascular impact. A separate analysis in sleep medicine found that adults who ate within 60 minutes of sleep onset had significantly reduced slow-wave sleep and elevated nocturnal heart rates compared to those who maintained a minimum 2-hour pre-sleep fast. Target dinner completion by 7 p.m., a 3-hour gap before a 10 p.m. sleep target. If your lifestyle makes earlier dining challenging, prioritize the composition of the evening meal: smaller portions, lower glycemic index, reduced saturated fat, which reduces the digestive autonomic burden even if the 3-hour gap is not always achievable. And never eat a large meal within 1 hour of sleep under any circumstances. This is the interval at which sleep architecture disruption is most severe and most direct. Number 2, skipping or mistyming medications. From a sleep medicine and cardiac physiology perspective, the medication timing issue most directly relevant to nocturnal cardiovascular safety is the relationship between antihypertensive drug plasma concentration curves and the specific phases of the nocturnal blood pressure cycle. Blood pressure during sleep is not constant. It follows the sleep stage cycle, rising during REM sleep, when sympathetic activation drives the vivid physiological correlates of dreaming, and falling during deep slow-wave sleep, when parasympathetic dominance and reduced metabolic demand allow blood pressure to reach its daily nadir. This REM-associated blood pressure elevation is particularly significant for cardiovascular safety because REM sleep is disproportionately represented in the final third of the night, meaning that blood pressure surges are most frequent in the hours immediately before waking, precisely the period of highest cardiovascular event risk. When antihypertensive medications are taken in the morning, their pharmacological effect peaks during the daytime and wanes progressively through the evening and overnight hours. By the time the REM-associated blood pressure surges of the final sleep hours arrive, the period of highest cardiovascular risk, the medication may be providing only a fraction of its peak protective effect. Evening or bedtime antihypertensive dosing aligns the rising phase of the drug's plasma concentration with the blood pressure challenges of the overnight sleep cycle, providing coverage precisely when it is most needed rather than when it is least needed. Additionally, for adults taking medications that affect cardiac rhythm, cardiac output, or blood coagulation, the nocturnal period is the time when rhythm disturbances, ischemic events, and thromboembolic complications are most likely to occur. Having these medications at therapeutic plasma concentrations during sleep is not a minor consideration. It is a core element of their protective function. The MAPEC study, Monitorization Ambulatoria para Prediction de Eventos Cardiovasculares, randomized over 2,000 hypertensive patients to either morning or bedtime antihypertensive dosing and followed them for more than 5 years. The bedtime dosing group had a 61% lower rate of major cardiovascular events, including myocardial infarction, stroke, heart failure, and cardiovascular death, compared to the morning dosing group. This finding has been replicated in the subsequent Hygia chronotherapy trial involving over 19,000 patients, which found consistent and significant cardiovascular risk reductions with bedtime antihypertensive dosing across all patient subgroups. Initiate the conversation with your prescribing physician about medication timing at your next appointment. Bring your home blood pressure log, particularly readings taken at bedtime and upon waking before medication. Ask whether chronotherapy, timed medication dosing, has been considered for your specific antihypertensive regimen. This is a low-cost, zero-risk conversation that could produce the most significant cardiovascular risk reduction available to you without changing anything about your medication itself. Number 3, undiagnosed sleep apnea. From a sleep medicine perspective, obstructive sleep apnea is not simply a breathing problem that disrupts sleep. It is a systematic, nightly assault on every component of the cardiovascular regulatory system that sleep is designed to protect, and its cardiovascular consequences are as severe as any traditional risk factor in the clinical literature. Let me walk through what happens to the cardiovascular system during a single obstructive apnea event, because the sequence is both remarkable and alarming. The airway collapses. Breathing stops. Intrathoracic pressure, the pressure inside the chest, changes dramatically as the respiratory muscles continue straining against the obstruction. This negative intrathoracic pressure is transmitted directly to the heart, creating mechanical stress on cardiac chambers and increasing the work required for each heartbeat during the obstruction. Simultaneously, blood oxygen levels begin falling. The chemoreceptors, the oxygen sensors in the carotid body and aortic arch, detect the desaturation and signal the brain. The brain triggers an arousal response, a partial waking that activates the sympathetic nervous system. Noradrenaline floods the circulation. Heart rate accelerates. Blood pressure spikes. The airway muscles contract, clearing the obstruction. Breathing resumes. Oxygen saturation recovers. And then, within minutes, sometimes seconds, the cycle begins again. In moderate to severe sleep apnea, this sequence repeats 30 to 100 or more times per night. Every repetition is a sympathetic cardiovascular stress event. Every repetition produces the blood pressure spike, the arrhythmic trigger, and the hemostatic activation that are associated with cardiac event risk. And the cumulative structural consequences, ventricular hypertrophy from chronic pressure overload, atrial remodeling from chronic pressure and hypoxic stress, endothelial dysfunction from repeated oxidative stress during desaturation events develop over months and years of untreated disease. The Sleep Heart Health Study, the largest prospective epidemiological study of sleep apnea and cardiovascular outcomes, found that adults with severe untreated obstructive sleep apnea had a cardiovascular mortality risk 2.87 times higher than those without sleep apnea after full adjustment for conventional cardiovascular risk factors. This is a risk magnitude comparable to active smoking in a condition that can be effectively treated with a CPAP device. Know the screening criteria. Habitual loud snoring. Observed apneas, breathing pauses witnessed by a bed partner. Waking with headache, dry mouth, or a sense of unrefreshing sleep. Excessive daytime sleepiness despite adequate time in bed. Frequent nocturnal urination, a less well-known apnea symptom driven by the atrial natriuretic peptide released, during the repeated intrathoracic pressure changes of apnea events. If 2 or more of these are present, discuss a sleep study referral with your physician. The diagnosis is straightforward, the treatment is effective, and the cardiovascular benefit of treating sleep apnea in an affected individual is among the most significant risk reductions available in preventive medicine. Number 4, dehydration. From a sleep medicine perspective, nocturnal dehydration has cardiovascular consequences that operate through both the hemostatic pathways described in previous videos and through a sleep-specific mechanism that is rarely discussed: the effect of dehydration on autonomic nervous system function during sleep. The autonomic nervous system, specifically the balance between sympathetic and parasympathetic activity, is the primary regulator of cardiovascular function during sleep. Heart rate variability, nocturnal blood pressure dipping, the smoothness of sleep stage transitions, all of these are expressions of autonomic balance. And dehydration directly impairs autonomic regulation. When plasma volume is reduced, as it is in a dehydrated individual, the baroreceptors that monitor blood pressure and regulate autonomic cardiovascular responses are working against a reduced circulating volume. To maintain adequate blood pressure in the face of this reduced volume, the sympathetic nervous system increases its baseline tone, sustaining a degree of sympathetic activation during sleep that should be progressively giving way to parasympathetic dominance during deep, slow-wave sleep. This dehydration-driven sympathetic persistence during sleep reduces heart rate variability, impairs nocturnal blood pressure dipping, increases nocturnal heart rate, and shortens the duration of deep, slow-wave sleep, all of which are markers of increased cardiovascular risk that have been independently associated with cardiac events in prospective epidemiological research. A study published in Physiology and Behavior found that mild dehydration, a fluid loss of just 1 to 2% of body weight, produced measurable reductions in heart rate variability during sleep alongside increased sympathetic activation markers compared to adequately hydrated controls. The researchers concluded that even the degree of dehydration routinely achieved by adults who do not actively monitor their fluid intake is sufficient to meaningfully impair nocturnal autonomic cardiovascular regulation. A separate study from the American Journal of Clinical Nutrition found that chronic low fluid intake was associated with elevated resting heart rate and reduced baroreflex sensitivity, both established cardiovascular risk markers, in community-dwelling adults over 55. Frontload daily hydration. Consume 1.2 to 1.5 liters of water before 4 p.m. Include water-rich foods, fruits, and vegetables in your evening meal. Place a 150 to 200 milliliter glass of water on your nightstand for nocturnal sipping upon waking. This partially compensates for the respiratory and transepidermal water loss that continues throughout the night without generating enough urinary urgency to significantly disrupt sleep. Number 5, poor bedroom temperature control. From a sleep medicine perspective, bedroom temperature is the most underappreciated environmental variable in cardiovascular sleep hygiene. And the reason it matters so profoundly is its direct relationship with the sleep architecture changes that determine whether the cardiovascular system receives the recovery it requires from each night of sleep. Sleep onset is triggered, in part, by a fall in core body temperature, a drop of approximately 1 to 2 degrees Celsius that is actively mediated by peripheral vasodilation, which dissipates heat from the body surface. This core temperature drop is not simply a consequence of sleep. It is a physiological requirement for sleep initiation and for the progression into deep, slow-wave sleep. Without it, sleep onset is delayed, slow-wave sleep is reduced, and the cardiovascular recovery that depends on deep sleep is curtailed. When the bedroom is too warm, above approximately 22 degrees Celsius, the peripheral vasodilation required for core temperature reduction is insufficient to overcome the environmental heat load. Sleep onset is delayed. the proportion of slow-wave sleep in the night is reduced, and the cardiovascular system does not receive the full duration of low pressure, low demand, parasympathetically dominated slow-wave sleep during which blood pressure reaches its cardioprotective nadir. When the bedroom is too cold, below approximately 16 degrees Celsius, the body's cold defense mechanisms, peripheral vasoconstriction, shivering, increased metabolic heat generation, activate sympathetic pathways that sustain nocturnal blood pressure elevation. The vasoconstriction produced by cold exposure increases peripheral vascular resistance and raises the pressure against which the heart must pump throughout the night. Both extremes produce the same cardiovascular outcome: impaired nocturnal dipping, reduced slow-wave sleep duration, and sustained sympathetic activation during the hours that should be the most cardioprotective of the entire 24-hour cycle. Research from the Journal of Sleep Research found that bedroom temperature was the strongest environmental predictor of slow-wave sleep duration in adults over 55, more significant than light exposure, noise level, or mattress firmness. Adults who slept in rooms maintained at 18 to 20 degrees Celsius had significantly longer slow-wave sleep durations and significantly greater nocturnal blood pressure dipping compared to those sleeping in rooms outside this range. A large population study from Scientific Reports found that adults sleeping in warm environments, defined as above 23 degrees Celsius, showed significantly elevated nocturnal heart rates and reduced heart rate variability compared to those sleeping in cool environments, with the cardiovascular effects most pronounced in adults over 60 with pre-existing hypertension. Set your thermostat to between 18 and 21 degrees Celsius before sleep, every night, consistently. Use layered bedding for personal warmth adjustment without requiring room temperature changes. Ensure air circulation. A slightly open window or a fan on a low setting maintains the air freshness that supports the respiratory function of sleep without creating the localized cold exposure of a directly aimed airstream. Avoid electric blankets on high settings. Localized heat impairs the core temperature drop that sleep initiation requires, even when room temperature is appropriate. And consider the bedroom temperature as a medical variable, as worthy of deliberate daily management as your blood pressure reading or your medication timing. Here is the complete heart-safe nighttime routine, structured from 6 p.m. through to sleep, addressing every autonomic, hemostatic, and sleep architecture vulnerability we have discussed today. 6 p.m. dinner window, final full meal of the day, completed by 7 p.m. Moderate portions. Emphasize foods that support parasympathetic tone and sleep onset. Complex carbohydrates increase tryptophan availability for serotonin and melatonin synthesis. Magnesium-rich foods, leafy greens, nuts, seeds, support the parasympathetic nervous system function that underlies both deep sleep and nocturnal blood pressure dipping. Avoid alcohol after the meal. Alcohol fragments sleep architecture and suppresses slow-wave sleep even in quantities that produce no subjective sensation of impairment. 7 p.m. hydration window, 300 to 400 milliliters of water, consumed between 7 and 8 p.m. Herbal teas chamomile, passion flower provide both hydration and mild anxiolytic effects that support the parasympathetic transition into sleep. All caffeinated beverages eliminated by 2 p.m. The 5 to 7 hour caffeine half-life means that afternoon caffeine is sustaining sympathetic cardiovascular activation well into the evening hours. 8 p.m. medication window. Evening cardiovascular medications taken consistently and at the same time each night. If chronotherapy has been discussed and indicated by your physician, bedtime antihypertensive dosing implemented at this time. Phone alarm set. Pill organizer used. The consistency of medication timing is as important as the medication itself. 9 p.m. environment window. Bedroom thermostat set to 18 to 21 degrees Celsius. Room darkened. Ventilation confirmed. All screens eliminated or blue light filtered. The melatonin suppression of evening screen light exposure is directly relevant to sleep onset timing and to the slow wave sleep duration that determines nocturnal cardiovascular protection. 9:30 p.m. wind down window, 5 minutes of slow diaphragmatic breathing, 4 counts in, 2 hold, 6 out. This respiratory pattern directly activates the parasympathetic nervous system through baroreflex and respiratory cardiac reflex mechanisms, reducing nocturnal heart rate, lowering blood pressure, and preparing the autonomic nervous system for the parasympathetic dominance of deep sleep. This is not a relaxation technique. It is a physiological cardiovascular intervention with a measurable effect on nocturnal blood pressure and heart rate variability. Sleep position, left lateral decubitus, left side down, is the sleep position most associated with optimal cardiac anatomy, reduced nocturnal acid reflux, and improved venous return. For adults with suspected or confirmed sleep apnea, any lateral position is significantly preferable to supine, which promotes airway collapse and maximizes apnea frequency and severity. When waking during the night, which becomes increasingly common after 50 as sleep architecture becomes more fragmented, pause before moving. Rapid standing from this low-pressure state risks orthostatic hypotension that is more severe than its daytime equivalent. Sit up slowly. Pause at the edge of the bed. Stand deliberately. Use a nightlight to eliminate the fall risk of disoriented nocturnal movement. And drink from your nightstand water glass before returning to sleep. 5 habits. 5 mechanisms. 5 changes that collectively transform the nocturnal cardiovascular environment from a period of unmanaged risk to a period of active protection. Habit 1. Late heavy eating disrupts sleep architecture, impairs slow-wave cardiovascular recovery, and prevents the nocturnal blood pressure dipping that is one of your heart's most important nightly protections. Fix. Dinner complete by 7 p.m. Habit 2. Medication mistiming leaves the nocturnal blood pressure cycle, including the REM-associated surges and the pre-waking cortisol surge, inadequately covered by antihypertensive protection. Fix. Discuss evening chronotherapy with your physician. Habit 3. Undiagnosed sleep apnea produces repeated nightly sympathetic cardiovascular stress events, drives progressive structural cardiac changes, and elevates the risk of nocturnal arrhythmia, myocardial ischemia, and sudden cardiac death to levels comparable to active smoking in affected adults. Fix. Investigate if the warning signs apply to you. Habit 4. Dehydration thickens blood, impairs autonomic cardiovascular regulation during sleep, and creates the hemostatic conditions for nocturnal and early morning clot formation. Fix. Front-load daily hydration before 4 p.m. Habit 5. Poor bedroom temperature disrupts slow-wave sleep, impairs the core temperature drop required for deep sleep initiation, and sustains sympathetic cardiovascular activation through the hours designed for parasympathetic cardiovascular recovery. Fix. 18 to 21 degrees Celsius every night. Sleep should be the most restorative period of your cardiovascular day. For most adults over 50 who are engaging in the 5 habits we discussed today, it is not. It is a period of unmanaged and often compounding cardiovascular stress that accumulates silently and invisibly night after night into the risk profile that eventually produces a cardiac event that nobody saw coming. That accumulation is reversible. The habits are changeable. The routine we built tonight is implementable, starting this evening. Please hit the like button if this video gave you information that changes how you think about your nights. Subscribe for weekly content. And share this with someone over 50 whose sleep you have concerns about. Leave a comment telling me which of the 5 habits you are changing first. Your commitment, made here, is the one you are most likely to act on.